Thank you, and thank you again for the invitation to come and talk to you. Many of you have been through SGPGI and Pediatric Endocrine Unit, and therefore many of you may have already heard most of this talk. And I haven't changed a lot of the slides, but I'm trying to look at it from the point of view of safety and controversial issues. And I want you to think about what you're doing with your patients. We've gone from very complex, or at least to me, complex genetics to complex clinical situations here. So the question is that what are we going to do with these patients? They almost all survive childhood cancer now, but it comes at a horrible cost. The greatest cost is in recurrence over the next 20 years, or new tumour or other abnormalities which are likely to damage or possibly kill the patient. And at the end of 20 to 30 years after a childhood cancer diagnosis, somewhere between 20 and 30% of the patients will already have died. And if you look at a publication from a couple of years ago on the excess morbidity and mortality amongst childhood survivors of leukemia, followed up for 25 years, the mortality rate is 20 times higher than the population of the same age. Their cancer incidence is 10 times higher, and they go to hospital and see lots and lots of doctors. Nearly 10 years ago, it was pointed out in this very good publication that the longer you go, the more likely you are to have complications, and the more intense the regime that was used for chemotherapy or radiation, the higher the risk there will be. So the relative risk for conditions like growth hormone deficiency, metabolic conditions, and thyroid conditions are very much higher than the population. Women have roughly 6 times the risk of premature ovarian insufficiency, and men not infrequently require hormone replacement treatment. The key feature, however, is that we need to recognise this problem and treat our patients better so that they can achieve a better quality of life. Just this year, we've published a very unusual collection of patients from the 25-year follow-up of all of our bone marrow transplants from 1985 to 2015, and those that have survived. And again, it's a question of safety after survival, really. Of the 384 children in the cohort, 212 only were alive after their transplant at the commencement of the study, and we confirmed the features that have been seen before of gonadal dysfunction, multiple endocrinopathies, thyroid cancer, second malignant neoplasms occurring commonly. Particularly, we identified gaps in management that everybody should know about, that informed fertility counselling is still not undertaken well, pre-treatment fertility preservation is often not offered, bone health, lifestyle modification, and long-term surveillance still need to be done better. And these days, there's even more problems. We don't just have to think about radiation and chemotherapy. Maybe there are questions of safety and controversy. We're now using checkpoint inhibitors to change the immune response and help the patients with tumours like gliomas survive for longer. There are many different sorts of medications available, lots of different monoclonal antibodies. The point that you need to know is that this is going to create a lot more work for you, because 30% of patients who've had these treatments will have thyroid dysfunction, over 10% will have hypophysitis, some will have adrenal insufficiency, diabetes, and hypogonadism, but it's irreversible in around 50%. So they are safe for keeping the patient alive for longer, but again, it comes at a new cost. And if we look at the late effects and quality of life in cancer survivors, you can see in the tall grey bars that no matter what aspect of life you're thinking about, people who've had these cancer treatments are worse off than the rest of the population. They don't do as well at school, they don't do as well with their jobs, with their financial situation, their marital situation, and they have far more problems than their peers. And they also have very significant memory processing deficits, which we'll address again. This was the St. Jude Lifetime Cohort Study, which is the biggest one in the world, looking at cancer survivors from childhood. And it was looking at neurocognitive function and social attainment in survivors, and you can see that it's not very good. The question is, why? Is it safe for the patient? Is it important they have good neurocognitive function? And particularly, is it important for their medical carers like you? And that's the reason. That's the cerebral vasculature of an adult who has had childhood cranial radiation. I'm sure none of you would like to have a brain that looked like that. And it's the reason why people have such extraordinary difficulties looking after themselves and trying to deal with all their many problems. I won't bore you with the details of cranial radiation causing hypothalamic pituitary damage. We all know that this happens and that we get losses of our hormones. Growth hormone is almost universally the first hormone to disappear, generally followed by gonadotropins and then the other hormones, but there's no absolute answer to this. So I'm just going to go through the various hormone deficiencies as a start and then talk about some other things. That after radiation through the brain and or the spinal cord, there's a significant risk of endocrine deficiencies. Even total body irradiation, which provides 12 gray to the brain as well as the rest of the body, can cause hypothalamic pituitary deficits, which is now said to be, in a recent publication, up to 50% if you follow these patients long enough. Both the radiation dose and the age of treatment are determinants of how bad the problems are, and they're all complicated by disinhibition of puberty. So puberty is early at the same time as one is losing one's growth hormone. Then if you've had spinal radiation, the spine doesn't grow and the patients become very significantly shorter at the end of adolescence. So it's important for you to look at all these issues. And this is just a patient who had the opportunity to have growth hormone with the passage of time. She had a medulloblastoma, treated with craniospinal radiation and chemotherapy, and she had severe posterior fossa syndrome after her treatment, which made her extremely unstable with very severe ataxia, so that she could not possibly walk down a corridor without practically banging into the walls on both sides. She did develop growth hormone deficiency, which was treated until the end of her adolescence, but you can see that she ended up shorter than other family members because she had the spinal radiation. At the end of linear growth, she was unable to get growth hormone for a while, and I think that's what happens in India at the moment. Once growth is finished, you can't get growth hormone unless you've got a lot of money. But she was able to get growth hormone and she improved enormously in her capacity to walk and to be coordinated. And instead of being looked after at home and having to be taken everywhere with a carer, she was able to be independent. She went to university and she now has a full-time job. And I think the growth hormone has made a huge difference. So is it safe? I think this was mentioned this morning, and I won't labour the point again, that the various long-term, very large patient cohorts that have been looked at with more than 400,000 patient years all told have failed to find an association between the use of growth hormone and recurrent tumour or new tumour formation. There is a very marked increase in meningioma after radiation exposure of the brain, but it's not different whether you've had radiation or whether you have not had radiation. So we're going back to those new targeted treatments with the immunological agents. There's no certain endpoint to them. If the glioma is doing well and is stable on an MRI, we're not stopping treatment. So should we be using growth hormone for a lesion that is currently being treated? It can provide long-term stability, and often the lesions that are being treated are midline and they are associated with growth hormone deficiency. But we put forward the question as to whether we should allow children not to have any treatment because they're on long-term immunologic agents, or whether we should be allowed to treat them. And the Australian government at least has reversed their decision on allowing the use of growth hormone. So we can now treat these children with growth hormone, but we don't really know whether it will reactivate a tumour that is only being held rather than treated by the immunologic agents. And so it's a question of safety. We know that a lot of these use the tyrosine kinase pathways, and that causes growth hormone inhibition. And when there is a drug holiday from the immunomodulator, often the children start to grow better again. But we don't know how long that's going to go for. We don't know whether it'll just stop again, whether they have hypophysitis, whether they stopped growing because they were sick and they just had a low IGF-1. We don't know whether they're going to finally lose height. So it becomes a question which nobody can answer at this time. But there is a huge change in the way malignant childhood brain tumours is being used, and you're going to see some new and serious questions to be answered over the next few years. ACTH deficiency is much harder to define. The St Jude cohort 10 years ago suggested that the risk for ACTH deficiency was quite low. We had a bit more, but there's a report just out this year which suggests that if you have at least 34 grey to the head, and most brain tumours are treated with somewhere between 40 and 54 grey, that the risk for ACTH deficiency is at least 20%. But it's hard to define. It's subtle, it's dangerous, it's very easy to treat if you recognise it, and you can improve patient safety. But there's very little data, and the data is very hard to assess. We don't know that if you use a synecthin test, where you can push the pituitary into working, you don't push the adrenal gland into producing a bit of cortisol, you don't know whether that patient will also respond when they're acutely ill. And you don't know whether you should start replacement treatment or just give stress cover to your patients. So I've been asked this so many times, I thought I would just mention it. It's very controversial as to what to do. Some people would treat all the patients when their cortisol level is low. But most of these patients have a morning cortisol level of somewhere between 100 and 125 nanomole per litre. We don't know whether we should give them stress cover or what we should do. So what I do is I ask the families, is the child more tired than other people? Is he or she sleeping after school? Are they unable to play with their friends and they'd rather just go to bed instead of going out? And if I feel that the cortisol levels are just getting lower and lower, and the child is very tired, we'll give a trial of cortisol replacement for a month or 6 weeks to see what happens. If it makes no difference whatsoever, I don't force the patients to use it, but I always give them information about stress cover, and they always have injectable hydrocortisone at home for emergencies. And they only start continuous treatment when it becomes obvious that they have complete cortisol deficiency. So if we look at hypogonadism after cancer treatment, we know that radiotherapy to the gonads causes loss of oocytes. The younger the patient, the more oocytes they have, and the longer it takes for the radiotherapy to cause hypogonadism. If you have radiotherapy to the ovaries around the age of 10 or 12, it may take 2 or 3 years to develop hypogonadism. If you have radiotherapy at the age of 25, ovarian failure happens almost immediately because by that stage the woman has less eggs. Unfortunately, it's complicated by all of the features of loss of restraint on puberty, which occurs with cranial radiation, evolving hypogonadism from the radiation to the head, and the complicated by chemotherapy as well. So it becomes a combined feature, which is very difficult to make a clear diagnosis. So we try and collect in the girls as many eggs as we can. People have tried to use GnRH agonist during cancer treatment in children to preserve oocytes for the future, and it has not been shown to be effective at all. They have tried to transpose the ovaries to the far lateral side of the sides of the pelvis before radiation in the hope to avoid a radiation hit, and that hasn't been shown to be effective either. If we are trying to measure the amount of oocyte function left, antral follicle count is the best marker of a reduced reserve, and if you combine that with inhibin B or AMH, that will predict the reserve. The problem is that AMH in adolescence is highly unreliable, and should not be used to tell the patient that they're going to immediately become hypogonadal. We do know, however, as I mentioned, that everybody is going to have an earlier menopause than in untreated patients. So we can do some things to help save eggs. Cryopreservation of ovarian tissue is difficult. If you're trying to collect oocytes only, it takes 2 weeks, and there usually isn't 2 weeks to take. But you can take a piece of ovary out and freeze it immediately before treatment, and it can be transplanted back into the woman in future years, where it will work for a while and it will provide menstrual cycles, but eventually the oocytes are recruited and eventually that tissue will fail. This is not, however, entirely without risk. It's not unlikely that there might be surgical risks of infection or bleeding. People who are acutely ill with an oncological diagnosis may have reduced oocyte function and quality anyway. We can't return that tissue to the body if the patient has had a tumour like leukemia, where the oocyte is ovary is likely to harbour leukemic cells, so it can never be put back. And as I said, that tissue will eventually fail. So if we need to treat ovarian failure, we know what to do. We know how to replace the ovarian function with increasing doses of estrogen and the eventual addition of progestogen. But I would ask that if you have the opportunity to see these patients and they're in the middle of puberty and have pubertal arrest during their treatment, don't delay hormone replacement treatment until they have finished their chemotherapy and radiation, because that might be in 2.5 years' time, and they can be really profoundly unwell from hypogonadism, which was completely unnecessary and which will waste a lot of bone in the interim. Is there anything else we should think of? There are safety issues as well. You will remember that nasty picture of the interior of the brain after cranial radiation. There have been a number of studies looking at MRIs and MRAs of people who have had cranial radiation, which clearly demonstrate an increased abnormality at a very early stage. targeted proton radiation is less likely to cause widespread damage, but it's quicker to cause local damage. And it takes 6 to 8 years if you have standard photon radiation. The only thing you need to look at here is those red things on the left, saying that the age of 45, and this is looking at survivors who had a first stroke, at the age of 45, the increased risk is enormous. Those who've had cranial radiation have a 10% risk of a stroke, 12.5% or more if they've had craniospinal radiation. 1 in 8 survivors will have had some form of symptomatic stroke by the age of 45. So there is something that you can do about that if you need to replace their gonadal function with estrogen. You need to use transdermal estrogen. You need to avoid the first pass effect on the liver and decrease the procoagulopathic effect of oral estrogen. This is very important. I think transdermal estrogen is probably becoming a little bit more available in India now, and this is a situation where it really should be used. There's another issue with gonadal function after bone marrow transplant, that this is a study that we undertook where overall 22% of our patients who had received total body irradiation and high-dose cyclophosphamide eventually had a spontaneous pregnancy. So you can't guarantee just because you had ovarian failure at the age of 12 or 14 that it will stay that way. It can improve, and even after 20 years of ovarian failure, some of these women will have a spontaneous pregnancy. The last thing you need if you have gone through all of this sort of treatment is to have an unplanned pregnancy. So we need to change our patients to contraception where required. The ovary can recover, and if they have an unanticipated pregnancy, think of all the things that have happened to them. If they've had anthracyclines as part of their original treatment, they're likely to have cardiac fibrosis and cardiac compromise. They may have lung fibrosis, thyroid disorders, a uterus that won't respond. There are so many difficulties of a pregnancy. So we need to be aware of possible recovery from ovarian failure. We need to be aware of the incompleteness of gonadotropin deficiency and cycling failure, and then choose some form of effective contraception, preferably not using the contraceptive pill. And again, it's unpredictable, it's late, and it's dangerous. Boys have, as we were talking about this morning, they have development of their testicular function from infancy onwards. It's a continuous process. And so if they have chemotherapy at any age, the higher the dose of chemotherapy, and then depending on the type of chemotherapy, they have a high risk of future infertility, particularly if they've used busulfan or high-dose cyclophosphamide, or if they've had radiation exposure. And again, a study published just this year demonstrates that with radiation exposure, even under 1 gray radiation exposure, you start to have a rise in FSH, demonstrating damage to fertility. Once you get above 10 to 12 gray, you start getting Leydig cell dysfunction as well. But almost no radiation will start causing fertility problems. We use a risk stratification table, and there are many published on the internet, so that you can easily calculate how much cyclophosphamide equivalent in various drugs has been given and what the risk for fertility impairment is. So we offer semen storage to the boys who are old enough before their chemotherapy or radiation. If you have a suitable urologist who is competent and the boy is too young or not able to produce a semen sample on demand when being acutely ill, electroejaculation is a perfectly reasonable option, but you must have somebody who is very competent using it. You need a small probe, and an inexperienced operator is likely to provide severe burns to the prostate. Testicular biopsy is the only thing that can be done if neither of those options are available. Over the age of about 12 to 14, once there is some enlargement of the testis, you've got a fair chance of finding a few sperm. And we do know that taking testicular tissue out in animals and autografting it back has resulted in baby monkeys being born. So we assume that this will be able to be done in humans. As a result of the research that has been undertaken over the last 5 or 7 years, we have gradually had an increased uptake on boys who are wanting to have fertility preservation, and they've been doing fertility preservation with testicular biopsy at a very high rate in our institution. It's a bit controversial that these are boys that have had testicular biopsies either before or during their puberty and before treatment. I've asked, there are about 45 of them who were eligible. We've got nearly half so far who have provided a semen sample years after their original treatment. 16 out of 19 had viable sperm, and 11 of those 16 had enough sperm to ensure future fertility. The lowest cyclophosphamide equivalent at which there was no sperm detected was 12 grams per metre squared, but even at much higher doses, there's been at least one, or two, I think, who have recovered completely from that. So we don't really know whether testicular biopsy is going to be terribly useful in future. And I don't want you to do any more with this slide other than look at the fact that it was published in Lancet Oncology 2021. The key features are that there have been many studies saying that healthcare providers are very uncomfortable counselling about fertility because they felt that they didn't know what they were talking about and had not had enough training. It was recommended that healthcare providers become familiar with the latest evidence-based guidelines, and that the person who is going to talk to the patient and to the family should be the person who knows what they're talking about and not just the person who's looking after the patient. So then we look at a few more people with regard to safety. When we give hormone replacement to our young girls who have ovarian failure, the first thing the mother says, is it going to cause breast cancer? Well, no, it's not going to cause breast cancer, but the breast cancer risk is markedly increased after radiation exposure. And this is a very sad study published a few years ago, looking at a group of women who had Hodgkin's disease, showing that after radiation exposure to the chest, they had a cumulative incidence of breast cancer 30 years later of nearly 20% for women aged 25 to 45, which is 25 times the population risk, but only, 25% of those patients had ever had any screening. So nobody's looking after these people. Thyroid cancer is a similar situation. We know that thyroid cancer risk is enormous after radiation exposure. It's usually multifocal papillary cancer. We have a very large cohort of patients under surveillance, 339 at last count. We do thyroid ultrasounds 2 years after radiation exposure and continue to do it every 2 years forever because the risk does not go away. The total number of patients so far who have had an abnormal ultrasound, bearing in mind that we start very early and we don't expect abnormality in all the patients, is 129. Of those, either after fine needle aspirate or because of the appearance, We have had thyroidectomies in 61, and of those who had thyroidectomy, 3/4 of them had a thyroid cancer. The question then is, when do we do fine needle aspirate? When do we do radiotherapy? When do we do surgery? None of these things are completely resolved. And if you are looking at thyroid cancer for the high-risk patients, you'll see that there are huge changes, and I haven't got time to go into them at the moment. But what I would point out to you that in this very high-risk group, we've recently just published a small number of patients who were aged between 4 and 16 at the time of radiation exposure. For one reason or another, they all had very tiny nodules in their thyroid excised with a total thyroidectomy, and there were very specific reasons for that. Nothing to do with the size of the nodule. And of those, they all had multifocal papillary thyroid cancer, sometimes that was locally metastatic. And so we are just cautioning that small nodules in a high-risk group do not have a lower risk of malignancy, and that they do not necessarily remain quiescent. And so you need to be very careful with this group of patients. People argue about how important this is, but I think it will there'll be quite a big change in the next few years. Bowel and bladder are not endocrine areas, but it's still very important because endocrinologists end up to being the only people who are looking after these patients as they get older. They may go and have their MRI of their head once every year or two, but nobody else is looking after them. And if they have had radiation exposure, either with spinal radiation or total body radiation in childhood, the risk for bowel cancer rises exponentially. It's currently stated to be above the age of 35, but when you think about it, these are other studies, when you think about it, our patients, by the time they're around 20 years of age, it's probably 16 years for some of them since they were irradiated. And this was a case series of 13 survivors of childhood cancer with gastrointestinal polyps found at colonoscopy or gastroscopy. The mean age of detection was 26 years. Most of the abnormalities were tubular adenomas. The time to the polyps was 21 years. And unfortunately, already 3 of the patients aged 20, 28, and 36 had bowel cancer, one of whom died. The arguments at the moment are whether we should undertake regular colonoscopy for our patients or whether we should do PET scans. I'm afraid I can't see why a PET scan would be a better option, given that it's very expensive and more radiation to the patient. Fecal occult blood testing is a sensible option if you have a good fecal occult blood test. We certainly don't. There's a good one in the United States that looks at DNA, but generally there are no good fecal occult blood tests. And what if you have a whole pile of polyps that aren't bleeding? You're not going to detect anything. So we think that this is something else that endocrinologists are going to end up having to look at for their patients. There's been many studies done on psychosexual functioning in both men and women after childhood cancer, and you can see from both sides that they don't do very well. That although 20 to 30% at least of the patients complain that they have some psychosocial and emotional difficulties, very few have ever sought or received any form of counselling. This isn't safe or controversial. There are more things like diabetes, metabolic syndrome, and poor bone health that I haven't got time to go into, but all of these problems are increased in patients who have had childhood cancer. If we look at survivorship programs, we can see that less than 75% of eligible patients actually go to the clinics that are provided. research is not available, and there's no money for it. So only 29.8% of the institutions caring for patients said that more than 3/4 of the patients turned up. Lack of time, lack of funding, and seem to be the main problems. So what can we do that's better? Are there gaps? There's evidence for all of the endocrinopathies. There's evidence for brain injury. There's issues related to different sorts of radiation. There's contributions from genetic abnormalities. There's some evidence regarding when we should start surveillance. It's controversial how often these patients should be seen, when we should stop seeing them, if ever, and how long to follow them up for, and what the diagnostic accuracy of our screening modalities are, remains a matter of argument. So the one thing that I wanted to mention was that parents and families of children who've had cancer treatment never get over the problem, and they're never cared for. There's no adequate understanding for the families. There's very little supportive care, and they are distressed, and they carry that distress over into the young survivor for the rest of their lives. So I would like, if you do see these patients, to please take care of the families as well.